Hi, this is Morgan Aratola, and this is my video for the fourth case connection. So today I chose case one to begin with, and a brief preview. It's a newborn girl appears normal birth weight, but within 24 hours developed lethargy, hypothermia, and apnea. The physician suspects a metabolic disorder and orders a lab panel. Which diagnostic test would be the best to distinguish between a urea cycle disorder and a beta oxidation disorder? And I chose plasma glutamine, and I chose this because plasma glutamine will be the best diagnostic tool to differentiate between a defect in beta oxidation and or a urea cycle disorder. Because glutamine is the non-toxic nitrogen carrier and non-essential amino acid that is formed from the catalyzation of glutamine synthetase preceded by glutamate in the mitochondria. And glutamine plays an important role in the detoxification and transport of nitrogen, which can then be recycled via the liver. So important to note that that pathway is either working or not working. And with beta oxidation, that's not a pathway present. So the reaction between glutamate and glutamine synthetase also fixes free ammonium in the process of creating the glutamine, which then reacts with glutaminase to free ammonium, and then that is transported back to the urea cycle. And because there's a defect along this pathway, glutamate is being catalyzed by glutamine synthetase to fix the free ammonium. And then glutamine can go to the liver where it will undergo catalyzation by the enzyme glutaminase. And due to this patient's presentation, the serum blood test would elicit a better clinical diagnosis than the other three. So then the case goes on and a full blood workup is done, and ammonium levels are elevated, as is orotic acid, and citrulline was normal, which is important to note. So the patient has high levels of blood ammonia, which is toxic and very damaging to the central nervous system and can appear as lethargy and some of the described symptoms. And so if ammonia levels are high, then there's a deficiency in the body's ability to get rid of that ammonia as waste via the urea cycle. So the condensation of carbon dioxide, ammonia, and ATP in order to form the carbamoyl phosphate is catalyzed by the only rate-limiting step of the urea cycle, and that is the enzyme carbamoyl phosphate synthetase 1. And a defect in this enzyme function would lead to an increased ammonia level. With the orotic acid, the mitochondria are unable to use carbamoyl phosphate, and increased excretion of orotic acid is caused by a deficiency in the enzyme uridine monophosphate synthetase. This enzyme is important in that it catalyzes the formation of uridine monophosphate, which is the energy carrier molecule of a lot of important pathways. So orotic aciduria is an autosomal recessive disorder that affects chromosome 3. So parents could be carriers, or one of them is at least. And type 1 orotic aciduria is more reflective of a deficiency in hepatic ornithine transcarbamylase and is due to an increase in the biosynthesis of pyrimidines. In this case, the citrulline levels are normal, so there is likely not a deficiency in the enzyme arginosuccinate synthetase and or arginosuccinate lyase. Both of those arginosuccinate, not tate. So that leads to the next case, which is case 3. Brief history: 47-year-old man presents with severe pain in his right great toe. So immediately you're kind of heading towards the gout theory. And it turns out that after his lab findings, he has gout and is diagnosed. And so his blood workup is done, and he has a low urinary uric acid level and a high plasma urate level. and that's the result of those. So then the question is, what is the best explanation for the presentation of this gout? I put decreased salvage of purines. The main causes for higher plasma urinary acids are either low excretion, higher synthesis, or both. And so it could be renal. Somehow the urinary acid isn't getting out. So a lot of the times the kidneys can be affected and they aren't able to properly excrete and or synthesize the uric acid. So gout is a painful rheumatic disease caused by the deposition of monosodium urate monohydrate microcrystals, or uric acid, more commonly known. And it primarily affects the joints, but it can also affect a host of other tissues. And it's usually in a healthy individual excreted renally. But in this case, something is going on that's not allowing that to happen. So other tissues can be affected by the overproduction or underexcretion of poorly soluble uric acid, which is the end result of dietary purine metabolism in humans. And humans lack an enzyme called uricase, and uricase catalyzes the degradation of uric acid to a more soluble product that's easily eliminated. And it's kind of interesting that other species have mutated this so that they can excrete it properly. So anyway, as a result, the serum levels in humans of this enzyme are the limit of its solubility. And so hyperuricemia is a risk factor for gout, but like in this case, gout can occur when serum uric acid levels are low. And because this patient has hypouricemia, this could be due to a deficiency in the enzyme xanthine oxidase, which catalyzes the formation of uric acid from xanthine. An additional test, which I wrote test, either genetic or hepatic in nature, would be helpful to diagnose the xanthine levels. Hyperlactic acidemia, so elevated blood lactate, due to an increased ratio of lactate to pyruvate, could also be a good indicator metabolically of what's going on. So you'd probably expect to see a high lactic acid value, probably greater than 2 millimoles. Factors that impact the uptake of urate by the kidneys are plasma concentration, plasma volume, renal plasma flow modulators, so maybe medications that he's on. And as such, renal excretion of urate follows the same extrarenal limiting factors as glomerular filtration. So a lot of times with these patients, they have a host of things going on: kidney, liver dysfunction, or a specific genetic defect for a said enzyme. So then we also now discover that he drinks a lot of soda, like 5 liters a day. So the potential impact of this is changing to a diet high in sugar, such as soda, is proven to be very, very deleterious physiologically. So fructose is the primary ingredient in many sodas, and when fructose is broken down in the body, it's different than other sugars in that the body releases purines, and studies have shown that increasing this fructose intake leads to an increase in serum acid levels. And fructose also reduces the intracellular ATP levels, as well as nucleotide turnover, so it generates more uric acid than your body can maintain to maintain that homeostasis. Uric acid is the end product of purine metabolism by the enzyme previously mentioned, xanthine oxidase, which would be excreted by the kidneys. And this patient would also benefit from a renal panel just to see what's going on. Additionally, high fructose corn syrup, which is another form of fructose and found in a lot of kind of high sugar, high processed foods, And that is made of 55% fructose, so it has the same effects that you would expect to see from fructose. And the biggest thing this person needs to do is stop drinking soda, especially that much, and maybe switch to water. That's the easiest, quickest first step, because the diet is proven to increase obesity, metabolic syndrome. High purine diets are hard on someone who's already experiencing gout and increased levels like this patient. So thank you very much.